Okay, you can start when you're ready, Luca.
Okay, perfect. Hello and welcome to my presentation on my regional dermatology toolkit for Fibuspan. This project is a research study on regional skin conditions in Ecuador. So first, before we talk about the project, I'm going to talk about who I am. My name is Luca Hardy. I'm from Augusta, Maine, and I go to Princeton University. I'm planning on majoring in Spanish and Portuguese on a pre-med track. And why I applied to Patch. So there's a few different reasons. One is I really love doing humanitarian work. In high school, I went to Guatemala a few times and worked in schools. And then last January, I was able to go to Benin and do some more health-related humanitarian work, such as helping with cataract surgeries and building water wells. I'm interested in medicine. Like I said, I'm on a pre-med track. I also really love learning about Latin American culture and practicing my Spanish. At Princeton, I'm in a Latin dance group, but I've also taken some Latin American studies classes. And then really Patch's mission aligns with my values. So I really chose Patch because this mission reflected the kind of physician I hope to become. So someone who values not only treating patients, but also addressing like broader community health through education, sustainability, and partnership. What really stood out to me about Patch was that they had a commitment to working alongside local communities to create lasting improvements in health. And that approach really aligns with my own goal of practicing medicine in a way that prioritizes collaboration, education, and long-term impact. So now to the project. So project context is that this project addresses the top skin conditions and diseases affecting the Andean and Amazonian regions of Ecuador. The project will focus on region-specific prevention and education strategies that will help standardize screenings and profile the clinic's dermatological burden. The phases that were completed for this project were the readiness screening, feasibility planner, and project handoff. The only phase that wasn't completed was the implementation phase. So what I first had to do was do a literature analysis. I chose 11 articles, but 10 of these articles were about skin conditions, skin health, and risk factors in Ecuador. After, reading through all of them and taking notes, I completed an article summary and annotated bibliography for each article. And then from this, I was able to analyze articles to find the most common skin diseases, conditions, and risk factors. After this, I did an analysis of hospital data. But to do this, it took a lot of work because I had to find every CIE 10 code, which are basically codes that are used for like documentations in hospitals for different conditions. And so I had to find each code that I wanted to look for. And then I sent these codes to the Phoebus Statistic team to look through all the hospital data. From there, the data was collected. I was able to create an overall disease burden and geographic distribution of each condition based on the hospital data. After this, I had a conversation with Dr. Jorge Valdez, who is a local dermatologist here at Hubuspan. He basically confirmed my findings from my literature analysis and the data I collected from the hospital. He also confirmed that my research would be really helpful and would approved my solution of a regional dermatology toolkit. And he also gave recommendations. So from these three things came a few deliverables. So I have my literature analysis with my annotated bibliography. I have a bunch of data sheets that's including the CIE 10 codes, common patterns seen from the literature analysis, Phoebus-Spawn hospital data disease breakdown, and then hospital data patterns, and also two Google Forms, one for doctors to really ask about what conditions they see and how their like diagnosis process works, as well if they would use a regional dermatology toolkit. And then also one for patients to see what patients have been diagnosed with. And then also like if they would like more education on certain skin health and preventive strategies. So from all these things, I found three really big findings. One, that risk factors are different depending on the region. Two, that prevention, awareness, and specialist training are scarce. And then three, really the most common skin diseases and conditions. So starting with the first one, risk factors are different depending on the region. So this project really focuses on the Andean and Amazonian region. So for the Andean, this include high altitude, UV radiation, changes in temperature. And then for the Amazon, this included tropical climate, insects, and then occupational exposure. And I'm gonna go through each one and just say like why they're important. So really for high altitude, at higher elevations, the atmosphere is thinner and filters less ultraviolet radiation or UV. So as the altitude increases, our UV exposure increases, this placing people at greater risk for sun-related skin disease, sun-related skin damage. And these can be in like different conditions such as skin cancer, which is really seen from our literature, and then melasma and also sun allergies, which is seen from our hospital data. So really, because the Andes are at high elevation, people receive more ultraviolet radiation, increasing their risk for sun-related skin conditions. This kind of goes with our UV radiation as well. So as chronic UV exposure damages our skin cells and DNA, it's really one of our leading environmental risk factors for skin cancer and then premature skin aging. So this is also seen with like melanoma, non-melanoma skin cancers, skin allergies, and really long-term sun exposure contributes to both precancerous and cancerous skin lesions, as well as pigment disorders seen from our hospital data. And then changes in temperature. So really, our cool temperatures and low humidity can really dry out skin. And as the dry skin weakens the skin barrier, it increases irritation and inflammation. And so the cooler, drier climate in the Andes can contribute to the skin barrier damage and chronic inflammatory skin conditions, such as atopic dermatitis, contact dermatitis, and other inflammatory skin diseases. With the Amazon, this data is really supported from the literature, just because a lot of the hospital data is only focused in really the Rio Bamba slash Andean region. So with the tropical climate, the warm temperatures and high humidity create favorable conditions for microorganisms and parasites. It also increases fungal growth. So this hot, humid climate favors fungal infections and supports the life cycles of many disease vectors. This kind of also goes with insects. So many important tropical skin diseases that are seen in Ecuador are transmitted by insects. So these insects, are responsible for several parasitic skin diseases such as scabies. And also we have occupational exposure, which is also seen in the Andean region, but basically because many people are working in agriculture, forestry, or other outdoor occupations, they have like a higher increase with insects, plants, contaminated water, and prolonged sunlight. This can lead to fungal infections, contact dermatitis, and skin trauma, which leads to secondary bacterial infections. And also another thing that was kind of found with our risk factors is that there are really five main risk factor groups in Ecuador. There's environmental factors, demographic factors, clinical slash biological factors, socioeconomic slash healthcare factors, and occupational slash lifestyle factors. Number two, prevention, awareness, and specialized training are scarce in Ecuador. So the largest gaps identified were not only disease burden, but also prevention, early recognition, and access to dermatology expertise. This is really, really supported from the literature because basically every article that I read talked about limited dermatology access, delayed diagnosis, low public awareness of skin health, and limited preventative education. This is also supported by Dr. Valdez, where he talks about there needs to be a need for more standardized screenings, need for referral protocols, need for more provider education, and need for more patient education. And number three, really the most the biggest finding of this project is the most common skin disease and conditions. So from literature, we really see fungal infections, dermatitis, acne, which is a little bit different than what we see from our hospital data. So from hospital data, we see that acne had about 77 cases, which was like the number one common skin disease or condition seen through our dermatology cases at Phoebe Spawn. And then it goes atopic dermatitis with 33 cases, cellulitis with 22 cases, scabies with 12 cases, and then bowel warts with 11 cases. And a fun statistic is that about 1 in 3 dermatology patients, so 37.7%, were diagnosed with acne at Phoebe Spawn Hospital. So what is my proposed solution? So I'm proposing a regional dermatology toolkit for Phoebe-Spawn because based on my literature review, the hospital data, physician interviews, I found the greatest need was not simply identifying common skin diseases, but improving how they're recognized, managed, documented, and prevented in primary care. So rather than creating a new program, this toolkit would serve as a practical resource for healthcare providers by including regional disease information, screening and referral guidelines, standardized documentation, and then patient education materials. So the goal is really to improve early recognition of common skin conditions and strengthen referrals to dermatology when needed, promote prevention, and create more consistent data collection that can support future feed respond projects and patients. I also really chose a toolkit because it's practical, sustainable, and can continue to be used. It also builds on resources that FeedWithSwarm already has rather than requiring expensive equipment or additional personnel. So what will be included in the toolkit is a lot of things. There'd be a regional disease profiles, clinical photography of each condition, common diagnosis for each area, screening questions, treatment recommendations for primary care, referral criteria, patient education handouts, and then how to standardize our data collection. And now I'm going to talk about where confidence is a little bit limited in the project. So there's about 3 different aspects. There's number one, where the most common skin disease identified in hospital data reflect the most common conditions seen in the surrounding communities. Um, With the data that I collected, a lot of the hospital data is very limited on what I can see. So I really only get to see the CIE-10 code and then basically the street that the patient lives on. So by having more standardized data and more detailed data, it will really, really help this project and also help physicians at FeedRespond. So by continuing monitoring hospital diagnosis over time and then comparing with future data, it will help gain more confidence in this aspect. Next is that primary care providers benefit from a dermatology toolkit. The toolkit is really a recommendation from Dr. Jorge Valdez. So really just by obtaining more additional feedback from FeedRespond providers, especially using the Google form that I had already created, it will give us more confidence in this aspect. And then that patient education and earlier recognition will improve referrals and management. This aspect will gain more confidence once the implementation phase is done and the pilot phase, just because we need to evaluate referral patterns and patient outcomes really after the implementation. And then also with this one of the articles called Derm, a 4-step dermatology education digital toolkit for non-dermatologists in family medicine. They did a study out of 14 family medicine doctors about their knowledge of dermatology if they would use the proposed toolkit. And about 77% of them would agree that there wasn't enough dermatology teachings in their residency curriculum, and they would also recommend like having a toolkit to other providers. And I found this really important because it gives more confidence and evidence to support this project. And also, it had a really, really good quote where it says that dermatology is often an overlooked and underemphasized area of training and postgraduate primary care medical education, with abundance of dermatological education resources available, but no clear guidelines on how to best take advantage of them. And I find that really important to what's happening in Ecuador because in Ecuador, first, there's actually a limited amount of dermatological resources, and second, the guidelines aren't very clear. So this project really combats both of those problems. And so what surprised me most about this project? Number one, that acne vulgaris was the most common dermatological diagnosis in the hospital records, followed by atopic dermatitis, cellulitis, scabies, psoriasis, and brow warts. This demonstrated that many common skin conditions seen in primary care, different from the tropical and parasitic diseases that are often emphasized when discussing skin health in Ecuador. And number two is I also found it very surprising that melanoma was not a common diagnosis in the Phoebus data, especially since the Andean's high altitude increases the risk of melanoma for local communities. And with this one, there was only three cases of melanoma out of the 226 dermatology cases at Phoebus. So next steps for the project, step one is really a revision of information needed for the regional dermatology toolkit. For the toolkit, I have everything outlined and what should be put where, what questions should be asked. But if another future intern does take this over, then it'd be really important to just do a revision of the information and make sure that all the information they're putting in the toolkit is beneficial to the physicians. Step two is a revision of the format and design. Like I said, I do have a layout of how everything kind of should look, but actually the design of it is not, I don't have that. So that'd be, another big step. And then step three is to evaluate the data that's collected using the Regional Dermatology Toolkit. So this project is really meant to change. And by collecting more detailed data, we change the project to be more beneficial to physicians. So what Phoebus/patch we need to do to advance the work? First is obviously to pilot and refine the regional dermatology toolkit, then to do more standardizing dermatology data collection, establishing a dermatology referral protocol, train primary care staff in common skin conditions, develop patient education materials, and then to evaluate outcomes and update the toolkit regularly. And some feasibility considerations. So the regional dermatology toolkit is really intended to be provided for free. They're really the only fees would be development fees, and this would be printing education materials for patients, actually printing the regional dermatology toolkit for physicians, but the future intern could choose to just do this online. There's also could be a possible need for more skin-related preventions, such as sunscreen or fungal prevention remedies. And then really my biggest takeaway of the project. My biggest takeaway was that global health solutions should be built with communities, not just for them. Really working in Ecuador taught me that understanding local disease patterns, provider experiences, and community needs is essential before proposing a solution. Um, I worked with this a lot because it took me a really, really long time to figure out what my idea was going to be for this project. And also that the most effective interventions are developed collaboratively and adapted to the local context rather than copied from elsewhere. Yeah, and if you guys have any questions, please let me know. Thank you.